Oh yeah, I do see it. Yeah, live on Facebook. Cool.
We are live. Good afternoon, everybody, and welcome to another episode of Figuring Out Fertility. My name is Carolyn Dubé. I'm the Executive Director at Fertility Matters Canada, and I'm thrilled today to have Dr. Marta Wais here from Markham Fertility.
Hello.
It's the first time we've had someone from Markham Fertility on our series, so I'm thrilled to have you. And for everybody that's joining live on Zoom or Facebook, welcome. We're going to talk today about unexplained fertility. Can you hear me? How's my volume?
I can hear you great.
Okay, perfect.
Yeah.
Something that we hear a lot about and we get a lot of confusion and questions about. We run a lot of online support groups and we see patients talking about unexplained and they've just been diagnosed and they say, I don't know what that means and I'm frustrated. So I'm thrilled that you're here to kind of help us talk a little bit about how common this actually is and what patients can expect through their fertility journey. So I'm going to hand it over to you for a little bit. And if you're watching, please know that you can ask questions in the Zoom chat or on Facebook in the comment section. Dr. Wais, I leave it to you.
Thank you very much. I'm so glad to be here. Very excited. Okay, so I'm going to share my screen. And I have some slides prepared. Okay, so I think that's working, right? Okay, thumbs up, it's working. Okay, good, thanks. Sorry, you're muted.
Okay, perfect. Sorry about that.
That's fine, that's fine. It's just the new normal, right? Like all these Zoom meetings and generalized confusion. Yeah. So hello, everyone. I'm very excited to be here. I think this is a topic that is something that I have a lot of patient questions about because I think it's a very nebulous topic. It's a very not specific topic. And so I'm really hoping that we can kind of go through the topic, kind of explain what it is, what it means, what it doesn't mean, and sort of what the options are moving forward. All right, so unexplained infertility. So in the very basic definition, it basically means a couple that has infertility and there's no clear explanation why, which makes it very hard for people to kind of appreciate that or understand that, because I think everybody's question is always why, and how do I fix things? And unfortunately, this is one of those reasons where we don't know why. When we look at the textbooks, basically, this is a couple who has regular menstrual cycles, meaning approximately every 27, 28, 30 days, where we've confirmed that the fallopian tubes are open. So we will do that on a sonohistogram or a hysterosalpingogram, where the sperm, the semen analysis looks fairly normal, both count, motility, the general quality of the sperm, and the inside of the uterus looks normal, meaning that there's no polyps, there's no fibers kind of poking into the cavity. So when I see a couple for the first time, this is all the testing that I will do regularly. And sometimes we get all the results back and everything kind of comes back normal, but the couple's still not pregnant. The important thing to know is that with unexplained infertility, it does not take into account the age of the egg, so the age of the woman, or the age of the male. It has nothing to do with egg quality, so how good the eggs are. And the other big one is that it doesn't take into account endometriosis as well, which we see quite a bit in patients. So really, it's a diagnosis of exclusion, meaning that we do a bunch of testing, the tests come back normal, and we just sort of say, okay, you're unexplained. But it is so common. And I think that that's the really important takeaway point is that even though a couple might be experiencing unexplained infertility, it does not mean that they're like a medical mystery, that they're not alone, that there are many, many couples facing the exact same diagnosis, and that a lot of it can affect up to 30% of couples for sure that I would see in my clinic. It's certainly more common as the woman gets older, we'll see this unexplained infertility. And a lot of it's because, again, we're not taking into account the age of the woman when we talk about causes for infertility. But that's unexplained infertility is very, very common. And it really just means that the testing, the couple tests that we did, all came back normal. So people always ask me, okay, you know, if I have this diagnosis, you know, am I going to get pregnant, or am I never going to get pregnant, or what's going to happen to me? A lot of it will vary, of course, with the age of the female, which all fertility will vary quite a bit with that, of course, and also how long the couple's been trying to get pregnant. So for instance, a couple that's been trying for a year versus a couple that's been trying for, you know, 7 years or 8 years, that will have an impact on the likelihood they are of conceiving naturally. It's estimated that without any kind of treatment, without any kind of fertility assistance, the chance of conceiving each month is going to be about 2 to 4% each month. So for comparison's sake, a couple that is just starting out trying to conceive, so no infertility, just sort of trying to conceive for the first month or two, chance of conceiving is going to be about 15 to 20%. So it is a drop for sure, but it's also not zero. And so many couples do go on to conceive naturally on their own, but there's no guarantee, and it's a low likelihood. So I'm sure that sounds quite depressing, but the good news is that there are excellent treatment options available. There are lots of things we can do. So even though the infertility is considered unexplained, because it is so common, we see it so frequently, there are lots of people doing research on people with unexplained infertility. There's people writing guidelines about unexplained infertility specifically because it is common. And so we have very good evidence, we have good research and good studies out there telling us different things that we can do and ways to help a couple conceive. So one of the first steps, I think, for any couple trying to conceive, it's always looking at lifestyle and looking at lifestyle factors and modifiable factors. So although, you know, the research, although, you know, there's no study that'll say, yeah, if you smoke, you won't get pregnant, or if you quit smoking, you will get pregnant. But you really want to work on optimizing things as much as possible across the whole, across everything in terms of their health, right? So certainly, you know, quitting smoking will definitely be helpful. It's also very helpful, obviously, in pregnancy and as you go on, right? Limiting alcohol as well might improve fertility rates. So that's another thing to look at. Recreational drug use, we know, also will have a negative impact on fertility. And so limiting that can also help. Caffeine, we know, can increase the risk of miscarriage. And so trying to decrease caffeine intake is another way we can try and optimize things naturally as much as possible. You know, certainly trying to achieve a healthy body weight, or at least, you know, healthy diet and exercise will also help to try and optimize things as much as possible. And again, these are all things that will increase odds of getting pregnant, but they're also going to increase the health of the pregnancy and general health as well. So these are things I will talk to my patients about if I identify them when we on history. It's not a silver bullet. Like, it's not like a guarantee that, oh yeah, if you just quit smoking cigarettes, you're going to get pregnant. But it's all about trying to build and trying to improve your odds as much as possible. In unexplained infertility, a lot of the treatment options or things that we can offer in a fertility clinic will focus on boosting fertility and increasing odds of fertility, improving those odds of success. So we're going to kind of run through the list of different fertility treatment options, things I get asked about, sort of in a very general sense, and we can talk about their impact on unexplained. So the sort of starting from, I guess, least involved, least invasive to most involved. So a lot of people ask me about trying timed intercourse, but with oral agents. So using a medication like letrozole or clomiphene. So the idea is that when you take these medications, again, they're pills you take for about 5 days of the cycle, typically. The hope is that they try and get you to ovulate maybe more than one egg at a time, so that you're kind of increasing I always say like the targets for the sperm. So you're going to get to that, like the good egg or the right egg a little bit faster because you're ovulating more eggs at once. And combine that with timed intercourse or cycle monitoring, where we say, yeah, this day you're ovulating, you should have intercourse this day, this day, this day. When they've looked at this in couples with unexplained infertility, they really have not found any benefit. So although it might seem like a good treatment option for a lot of people, it really doesn't help or really doesn't overcome the issues that we see in unexplained infertility. So I generally don't recommend going down this road.
Was there any reason, or did this research sort of point to why there was no benefit, or do we know that?
Yeah, so with unexplained infertility, the thought is that, and again, these are theories, right? The thought is that there's something about the way the sperm and the egg come together that's not working, or it's the way the embryo is implanting into the uterus. Those are thought to be the most likely of the two reasons why there's no pregnancy resulting. And so when you're doing timed intercourse, you're not really helping the sperm and the egg come together. If a woman has regular cycles, usually the timing of the intercourse is not a major issue. I mean, healthy sperm will survive for, up to 5 days in the female reproductive tract. So that window of fertility is actually quite wide, even though that window of ovulation of when that egg is getting released is narrow. And really just increasing those eggs is not really a substantial difference. And so when they've looked at it, they've just said, probably no difference. The other one people ask me about is about you doing natural cycles, so meaning no medications with intrauterine insemination. So this stems from this thinking that used to be quite popular, that somehow it was the cervix or cervical factors, or what do they used to call? I think called like a hostile cervix or something like that.
Yes, I've heard that term.
Yeah, yeah. I always imagine in my mind this like angry cervix being like, no.
Yes, I've heard hostile cervix, hostile uterus.
Yes, yeah, absolutely. So basically, the reason why people would think about this treatment option is because, for that reason, that people think that there's cervical factors, that the cervical mucus is too thick, so the sperm aren't getting through, and that's why you're not getting pregnant, or there's something inhospitable to this about the cervix itself, that the sperm can't get past the cervix to get into the uterus. So when they've looked at studies and they've done research where they've had women who with unexplained infertility, where they've had them try this, there's maybe like a little benefit. So we're saying, like, let's say if the pregnancy rate was 4%, you might go up to like 5% or 6%. So it's difficult to justify going through the monitoring, the blood work, the ultrasound, the costs for that kind of increase. And so that's something I really will talk to my patients about and kind of try and kind of caution them against it, because you're talking about a very minimal increase for a lot of work and a lot of effort. Yeah,
that's completely understandable. And knowing, actually, as I'm listening to you speak to these different options and looking at the no benefit or minimal benefit, it's good to know that there's research backing these.
Yeah.
Making these decisions.
Absolutely. Yeah. And I think a lot of that research also around the cervix and the cervical mucus and a lot of that stuff, I think a lot of it has been kind of debunked a little bit over the past 10 years or so. So we don't use that terminology anymore, because it's we don't refer to the cervix or the uterus in that way anymore. But it's also been shown that it's probably not as important as we used to think in the getting pregnant, because we've also learned a lot more about embryos and embryology and the genetics and the metabolics in embryos. So that's all stuff we didn't know before, right? So the other one, kind of moving along, so IUI with oral agents. So again, this is the idea of doing these intrauterine inseminations after taking an oral medication. So the oral medication, letrozole, Clomid, again, taking over 5 days of the cycle generally to try and get a woman to ovulate more than one egg at a time. Now combining with the IUI. So instead of, telling a couple when to have intercourse, we take that sperm, the lab does a wash, and they put it up directly. The physician or whoever in the clinic will put it up directly at the top of the uterus. The idea with this is that you have, number one, more eggs, so more targets for the sperm. Number two, you're getting the timing right because, you know, we've monitored you. We know exactly when you're ovulating. Number three, the distance from the sperm to the egg is now a lot less, right? You're bypassing the vagina, you're bypassing the cervix, you're getting to the top of the uterus. The other thing is that you get more sperm into the female reproductive tract doing this, because in normal intercourse, the vast majority of sperm actually die off in the vagina. So the vagina is a very acidic environment. Sperm don't like it. They die very quickly. So healthy sperm have to get out of the vagina up into the cervix within minutes, basically, to be able to survive. And again, that's normal. That's completely normal and completely natural. But by doing the IUI, we're kind of boosting fertility in a couple of different ways, and it's kind of additive. So what's really interesting is that there is some benefit doing this. And it's actually, if you look at doing just IUI or just oral medications, somehow there's something about doing the two together that they work somehow in synchrony, and they give an even better pregnancy rate than what you would expect, which is interesting. Now, when I say a modest benefit, I'd say, you know, your IUI is limited in the sense that there's not many things that we can control for, and there's a lot of things we don't know. I don't know how many eggs there actually were. I only see follicles. I don't know the quality of the eggs. I don't know if the sperm got to the egg. I don't know if the sperm fertilized the egg. I don't know if there was trouble getting along the fallopian tube. I don't know if there was trouble of the embryo actually implanting into the uterus. So there's a lot of unknowns, which is okay, as long as you appreciate that going into it, that these are questions that we can't answer when we do IUI with oral medications. The modest benefit, so, you know, let's say if your pregnancy rate before is going to be maybe 4%, by doing this, you're going to go up to maybe like 10 to 15%. Depends on the sperm, depends on the number of follicles or the number of eggs that end up being ovulated out. And it depends on the age of the woman, of course, right? Mm-hmm. So it's not a massive pregnancy rate. It's not perfect. But it's a very reasonable thing to try, and most physicians will go this route first with unexplained infertility. Again, depends on the patient and depends on the age of the patient, being the number one factor probably. When I have a patient considering IUI and we were talking about this, I usually tell them, like, you kind of have to mentally prepare yourself to do it a couple of times. That you have to be prepared for that and kind of mentally buy into this idea. Because, you know, that cumulative pregnancy rate over a couple of IUIs is going to be much better than if we're looking at just one IUI.
How many? Oh, sorry. I was going to ask, how many IUIs? So if someone is going to get pregnant with an IUI treatment cycle similar to this, how many cycles can someone anticipate having to do?
Yeah. So there's no guarantee of pregnancy with IUI, but what we see is that there was a study that looked at this, and what they saw was that, okay, let's say you have 100 couples, okay, and they're going to start IUIs. So before they start their first IUI, nobody's pregnant, okay? After the first IUI, 10 to 15 couples will get pregnant, okay? If you look at the remainder, after their second IUI, another 10 to 15 will get pregnant, okay? Do a third IUI, another 10 to 15 couples get pregnant. Once you get to 4, though, the number of couples that get pregnant on their 4th or 5th IUI does decline. So you see it's sort of this leveling off of the pregnancy rate. So it's not to say that, like, nobody gets pregnant on IUI number 5 or number 6, because it absolutely happens. But again, you sort of have to look at, you know, risk versus benefit, right? Like, it's looking at the cost, the time, the energy versus the benefit, and where you're better to place your mental energy, financial energy,
absolutely,
and sort of where you are in sort of in your fertility journey. Absolutely. So it's a tough call, especially if you know, somebody previously conceived via IUI, and to know sort of when to move on to the next thing.
I have another question about IUI, especially with the oral agent. Mm-hmm. For those individuals or couples that conceive in one of these treatment cycles. Is the incidence of multiple births or higher order multiples, is it higher with these pregnancies or is it the same?
Yeah, you're stealing my thunder.
Sorry. Oh, I'm sorry.
It's okay. No, but you're absolutely correct, right? That is always the big concern when we talk about these medications where we're getting to ovulate more than one egg at a time. So you're always walking this fine line of, trying to get more eggs to kind of try and improve that pregnancy rate a little bit. And it's not a doubling, to be clear. It's not like one follicle, your pregnancy rate is X. And then if we have 3 follicles, your pregnancy rate is 3 times that. That's not how it works. Actually, the increase is pretty modest. But intuitively, it would make sense that your pregnancy rate would be higher and everybody. And so a lot of the time, you do try and push it a little bit, but you're right. That risk of multiples is the other thing. And that's the big drawback of going this route. So that's why, like Octomom and like John and Kate +8, they conceived via IUI with injectables actually. And people always think it's IVF that caused them like the high order multiples. But nowadays, actually, that's not so true anymore, for the most part.
Can we stay on multiples just for 1 second?
Yeah, absolutely.
So, I would love to know, because we do see this conversation happening in the support groups, and can you just touch on sort of why, I know we'll go down probably the IVF route in a bit, but the risk of multiples and why sort of best practice within Canada especially is to reduce the incidence rate of a multiple birth. Why is that important? I'd love to touch on that just quickly.
Yeah, absolutely. So I will tell you, so I'm a rare REI in that I follow my patients for prenatal care. I still do labor and delivery. Like I still do OB calls. So I see both sides of it actually. There's not many of us fertility docs like to do it, but I just find it fun.
That's so awesome. Just to follow through the whole process.
Yeah.
That's amazing.
I will say I've had patients where I've done the embryo transfer and then I delivered the baby.
Wow. That's awesome.
Oh, it's the coolest.
That is the coolest.
Yeah. I'm still waiting for the trifecta of egg retrieval, transfer, delivery. I'm keeping my fingers crossed. Yeah.
It'll happen
one day. But you're right. So multiples, truthfully, multiples, especially higher order multiples, I think they strike a little bit of fear in the heart of every OB. Because the risk of every obstetrical complication basically goes up once you're talking about twins and higher order multiples. Okay. We also take a different perspective on it because, let's say a patient gets pregnant naturally with twins. Okay. That happens. That's normal, completely natural, and absolutely it happens. And we follow along when we do what we can. When we feel like we caused the complication, because we do see it as a complication, when we feel that we caused it and we've brought on all of these extra risks onto our patient, we feel terrible about it. And so that's why we really try and minimize those risks. And that's why we really are so big on this. But really with twins and with higher multiples, you're looking at higher risk of gestational diabetes, higher risk of high blood pressure in pregnancy, so preeclampsia, higher risk the placenta is not going to be in the right spot, so a placenta previa, higher risk of needing a C-section, and all the complications that come with a C-section. So bleeding, infection, risk of damage to like bowel, bladder, all the stuff that's around there. Higher risk of the babies being born premature. And so when they're born premature, higher chance that they need to go to the NICU, that they would be admitted in hospital afterwards, higher risk of them being a low birth weight as well. And so all of these things come across. There's more monitoring involved, of course, in these twin pregnancies. And, even just on the woman herself, it's a much harder pregnancy carrying twins. Even looking past delivery, there's good evidence that actually the parents of people who have parents of twin pregnancies, higher rates of marital problems, actually higher rates of divorce. Because managing 2 newborns at the same time is significantly harder than 1 newborn at a time, which is already hard enough. And we're just talking about twins, so triplets, et cetera. You can imagine. Now, that's not to say that every twin pregnancy is going to end up like with all of these issues and all these complications, but we are really trying to do the best for our patients and minimize the risks while giving them a healthy pregnancy. Because really, truly, the goal is healthy mom, healthy baby.
Healthy baby.
Exactly.
Yes.
So, one baby at a time is better, healthier, safer option. But you're right. When you're talking about these medications, it's always that issue. And so that kind of leads into this idea of the oral agents versus the injectables, like the FSHs, LH, Gronal F, Puragon, Menopur, et cetera, et cetera. The people always say, well, should I be doing injectables with my IUI instead of an oral medication with my IUI? And I think it really depends, because if you're getting, 2 follicles with letrozole, for instance, or 3 follicles with letrozole, switching it to an injectable is not going to make much of a difference. That probably the pregnancy rate increase from using injections over pills is just because you get more follicles. So like if you're a person on Clomid or letrozole and you're making 1 follicle at a time, you're probably not getting that, benefit of multiple eggs, multiple follicles at a time. And so injectables might increase pregnancy rate a little bit. But again, we're talking about going from like 9% to like 11% pregnancy rate. So these are very, very small increases that we're talking about.
Thank you for clarifying that. I think that's a really important conversation, and important information for patients to really sort of digest and understand while they're making these decisions.
Absolutely. And trust me, I hear all the time that, one and done.
Yeah.
She's a twins. Absolutely. And I completely appreciate how that might seem like a great idea. And but it comes with a lot of risks, and it's important to have that discussion. Absolutely.
Awesome.
So that brings me to IVF. IVF, if anybody asks me what's the best way to get pregnant, the answer is always IVF. And that's the case pretty much for any fertility complication. That's not the tricky question. The tricky question is about when to do it and whether we can get pregnant in a different way before going to IVF. But for sure, it absolutely has the highest pregnancy rates. And with unexplained infertility, you're looking at, again, depending on the age of the egg, upwards of 50, 60, 70%. So it's a huge jump going from IUI to IVF when we look at pregnancy rates. The other interesting thing about IVF is that we always talk about it being both a test and a treatment. Because when you do IVF, it's the first time we actually see the eggs under the microscope. What do the eggs look like? Do they look good quality, not good quality? We kind of get that information. We actually see, okay, the sperm are there, they're swimming, but do they actually fertilize the egg? Can they actually stick in and do what they need to do? We are able to see the embryo development as well, which gives us a lot more information. And then, being able to do IVF, we can look at genetic testing and look at the genetics of the embryo. We're able to look at, things like the implantation. We were able to do things like an ERA test to try to figure out when to put the embryo back. So we can really have much better, fine tuning of all these different elements. And we can really do a lot more things to try and increase and improve that pregnancy rate as much as possible. And so that's really the power of IVF. And that's why we see much, much higher pregnancy rates with IVF. Absolutely. So again, it might not necessarily be the right first treatment for everyone, but it definitely is the strongest, most powerful one with the highest pregnancy rates. Absolutely.
Dr. Wais, when people have the option, so if I'm a patient and I'm seeing you, have unexplained infertility, do you find in your practice that more patients will go one route, try an IUI or a couple of rounds of IUI before going to IVF, or do you find the majority of patients will start with IVF? What's your experience there?
I think it depends on a couple things. Number one, how long the couple's been trying to conceive. So, I think if the couple's been trying for many, many years, I think they're, we feel like we can do better with IVF. Plus, you know, they're at a point where they're like, we just want to get pregnant. You know, we're just ready to go right into IVF. And of course, the age of the woman is a big factor as well. You know, unexplained infertility at 30 is going to be different than unexplained fertility at, you know, 42, for instance, right? That's going to change things a lot too. But I find most couples will go to try IUI first. And I think that's perfectly reasonable to give it a shot. I think it's also a great way to kind of ease into the fertility world or fertility treatments, like, you know, cycle monitoring and the blood work and the ultrasounds and that kind of rhythm.
That's a great way to put it, to kind of ease into.
Yeah.
There is a whole system and a process to any type of fertility treatment. So yeah, I really like how you coined that.
Yeah, absolutely. And so I think that sometimes that adding on that anxiety and the stress of that, you know, first cycle, plus making it like your IVF cycle, it's a lot to take on for sure. So I think, you know, trying IUI is perfectly reasonable. And, you know, like sometimes, and honestly, I've seen it work. Like, why not? Right?
Yeah, absolutely. Wow. That was some excellent information. I mean, I've been in the fertility industry for quite some time, and every time I do one of these sessions, I learn something. And there are definitely nuggets here that I was surprised at, and the information was really good for me. So I know that the people that are watching right now, whether they're on Facebook or Zoom, really took some really good information there.
And I'm glad.
Yeah. And so if you're watching on Facebook or Zoom, please know you can ask questions directly. We're going to go into the Q&A section now, and I do have some questions that have come through. So if you're on Facebook, you can put them in the comment section and in the chat section on Zoom. So here's a question. Oh, go ahead, Dr. Wais.
Oh, I was just going to say, Dr. Garcia, so she's another physician from Markham Fertility. She and I have done a bunch of Instagram lives. They're saved on her Instagram account as well. So you can always check those out as well. And we will be restarting at some point this year if you want to see more of me on video.
There's excellent information. Dr. Garcia does a great series. And I encourage you to follow both Dr. Wais and Dr. Garcia on Instagram, because your information and your delivery to patients is amazing. So thank you for continuing to educate patients across the globe.
Oh, our pleasure.
Your platforms. Okay, so some questions are starting to roll in. How much does sperm fragmentation factor into how good or healthy the sperm is?
So sperm fragmentation refers to the DNA in the sperm and the appearance of it and how fragmented it looks. And so truthfully, DNA sperm fragmentation is pretty controversial in the world of infertility, in the world of urology as well, as to how much of an impact that has. You know, not all clinics, not all physicians will do it routinely, sort of on a first semen analysis. I don't. It can also be kind of hard actually to access the test to actually have it done, I found recently. So it might have a role, but the problem is that, again, just like age or maybe mild endometriosis, it's very hard to tease apart what the factors are. In terms of DNA fragmentation, there is a little bit of evidence that maybe it has an increased risk of miscarriage in women, but not necessarily unexplained infertility per se. The problem is that we're not great at fixing it, the DNA fragmentation. So if we find it, we'll say, okay, well, you know, he can take a bunch of antioxidants, vitamins, etc. May or may not help, and it may or may not help in terms of conceiving. Nobody's really been able to show that it's made a difference.
Great, thank you for that. Good information. I have another one. I got pregnant from our second IUI, but my HCG level won't rise. Why does that keep happening? Is there something that is causing it?
So sorry, it didn't rise?
Her HCG level won't rise, she said.
Oh, won't rise. Oh, okay, I see. So the concern is that when we don't see that, so when we look at HCGs, we'll often trend them to see how that number is increasing. And there are some guidelines about how much we expect to see it jump. We used to talk about like the doubling, the 48-hour doubling. It's not really a doubling that we need. But we do want to see that nice steady increase in the HCG as a sign of a good, healthy pregnancy. It's hard. So basically, when the HCG is positive, we know that the sperm and egg have met. The sperm has fertilized the egg. So there's been an embryo made. It's traveled along the fallopian tube and it's stuck to the uterine wall. Okay, because that's when HCG production starts. When the HCG is not rising, into that, so there's something going on at that point. Now, it could be, most likely cause is that it's not a genetically normal pregnancy. And so we know that that's the most common cause of the very early miscarriages or these pregnancies where we don't see that HCG rising properly. So, you know, again, it could be age-related, age of the egg most often. But miscarriages are also quite common. I mean, they affect probably anywhere from 15 to 20% of pregnancies. But, you know, that would be another reason to think about IVF. Again, gives you those answers if you're doing the genetic testing and the embryos. Sorry, you're muted.
Sorry. I'm just going to stop sharing screen so that you and I can be, I think I can do that. So it's just you and I chatting. I don't know that I can do that. That's okay. Okay, so more questions are rolling in. Thank you. This is very exciting. I love when this happens. With as much as possible having been addressed, clean uterine cavity, euploid embryo, ERA, immune, can undiagnosed endometriosis be a reason for recurrent loss? Does endo impact blood flow to the uterus?
So certainly women with endometriosis, we do know that they have higher rates of miscarriages, lower implantation rates with embryos. So certainly it can contribute to increased risk of like recurrent miscarriage or recurrent pregnancy loss. Not in that it necessarily affects the blood flow to the uterus per se. It's probably, and again, this is more of a theory, there's probably just this like pro-inflammatory kind of, they call it a soup, basically in the uterus, in and around the pelvis, that makes the environment not so nice for that embryo, for the implanting. The problem is that it's hard to know what to do about that. So endometriosis is tricky in that you can have no symptoms and have terrible endometriosis, or you can have very significant symptoms and have very, very, very mild looking endometriosis. And the only way to actually make the true diagnosis is surgery. So a camera in the belly button, a laparoscopy, seeing it, taking a sample of it and sending it to pathology doctors who say, yeah, this is endometriosis. And, you know, women with endometriosis, we will often treat them in very similar ways in terms of IVF and the embryo transfers, et cetera. So it's certainly possible, but it's hard to know what to do with that information. And that's the tricky part. That's the tricky part. Yeah.
Great. Thank you for answering that question. Another question that has come in. We're starting IVF and I am on day 4 of STIMS. I have PCOS. I'm having PGTA testing done. We found out today I'm not responding well to the medications and they have increased the dose to see if it will help. Is there something I can do to help the medication?
So good question. So
I'm assuming it's stimulation meds that we're talking about. Yeah.
So PCOS is interesting. PCOS, it's for a fertility doctor, it's tricky in the sense that we know you have lots of eggs in the ovary, right? You have that high antral follicle count and maybe that high AMH. And so we know the eggs are there. It's just trying to figure out the perfect dose where we get a good number of eggs, but not so much where you're overstimulating. And so I think a lot of physicians, myself included, will always err on the side of a lower dose and then go up if we need to. So, you know, common things being common, I think that, you know, with a higher dose of medications, it's going to, your ovaries will stimulate. Again, maybe they'll have to up the dose a little bit more, and that's okay. You know, it's really your physician just erring on the side of caution, so you're not overstimulating and getting an ovarian hyperstimulation syndrome, which is good. That's not a road you want to go down.
Great, thank you for that. Okay, just jumping over to Facebook questions here. I had a lap done. I was diagnosed with stage 1 endo on the bladder and had the endo removed. I have high prolactin being treated with Dostonex, right? Level now normalized. Would I still be considered unexplained?
I mean, technically, yes. By definition, you would be, because the endometriosis doesn't really get taken into account for the diagnosis. And stage 1 is quite mild, which is a good thing, especially if it's been removed, right? So the prolactin, once it's normalized, we don't think that it causes any further issues. So yes, you would qualify and for the quote unquote like unexplained infertility, absolutely.
Okay, thank you. If a semen analysis is normal, is having DNA fragmentation testing worth looking into? Is it possible that even with a normal SA, that something else might be wrong?
Yeah, so a semen analysis, again, it basically tells us, okay, the sperm are there and they're moving. It says nothing about the sperm function, right? So for sure, you will certainly, there are times sometimes where you will see a man with a normal semen analysis. You go to IVF, you do conventional IVF fertilization and you get very poor fertilization. Like the sperm and the egg, the sperm just aren't meeting. And you're wondering, well, it could be the IVF process being in the lab, etc. Or you wonder, maybe that's why they're having difficulty conceiving. So it certainly does happen. We don't really have a good test of sperm function and that fertilizing capability, so to speak. So, I mean, I think, a DNA fragmentation might give you some more information. But again, you have to kind of think about what are you going to do with that information and how is that going to help? Again, if the fragmentation is high, they will just sort of talk about antioxidants and taking those vitamins. So oftentimes I'll tell people just to take the vitamins. It's often easier and like the risk is very, very low. The harm is very low to try and optimize sperm health as much as possible.
Great. That's a really good explanation. And thank you for that.
Yeah.
Another question. I've done 3 IUIs. My doctor wants me to do 2 more before we move to IVF. I've only had 1 follicle and she wants to increase my gonal F to 175. Based on your experience with this amount of gonal F, does it guarantee more follicles? Also, I'm 31 FSH of 9.6. I know it's hard to do medical questions like this.
Yeah, I wish it would guarantee more than 1 follicle. It's hard to know though, because as much as everybody's response to medication is going to be a little bit different for 1,000 different reasons.
For sure.
And even month to month, you can see a very variable response, even with the same dose in the same patient, which can be definitely hard and definitely frustrating sometimes. So, I think it's definitely reasonable to go ahead and increase those to try and get, that second follicle. But we know that, that second follicle is not probably going to make a huge difference in the pregnancy rate. Yes, a lot of people will do many IUIs. And again, it probably depends on the bigger picture in terms of, what the sperm test looks like, what the uterus looks like, and sort of what this physician experience is and what your previous IUIs have looked like. But, certainly I think knowing that if you are ready to move past IUI, you have to be ready to kind of move into IVF. There's no in between. Right. Which is kind of tricky sometimes too.
Awesome. Thank you for answering that. Another question. What is the likelihood of a hostile uterus? You briefly mentioned it, and are there ways to help combat it? My acupuncturist suggested baking soda to balance pH.
I'm curious where the baking soda is supposed to go.
I'm unsure.
Please do not put baking soda in your vagina. That's not a good idea because you're going to your vagina needs to be acidic. Because if it's not, like, that's how you get recurrent UTIs and yeast infections and all this stuff. So that acidity of the vagina really is super important and helpful for your general gynecologic health. In terms of eating the baking soda, or like drinking the baking soda, again, you really can't alter the pH of your blood or of your body because your blood always works in this balancing system. So like, let's say you drank, let's say you had you ate a lemon, something really acidic. Your blood will always balance out to keep that pH steady level. Okay. So even if you drank a bunch of baking soda, your blood would always balance out and your pH would stay the same. So you cannot alter the pH of your blood. And that's a good thing, because you don't want to be able to mess with that, because that's very dangerous for your general health. In terms of this hostile uterus idea, I mean, certainly probably some uteruses, we know there could be immune issues going on. There could be inflammation type issues going on, again, with that kind of mild endometriosis. It's difficult to know exactly what it could be or what it might be. A lot of people find acupuncture helpful it could even be stress related, and the stress response and all the steroid hormones that come from that. So I think it certainly can be helpful for some patients, as long as you like it, as long as you find it beneficial for your stress level. It doesn't make you more anxious. But we really don't know how to kind of fix these components. And we can kind of tease things apart. So we can kind of say, okay, let's say you have your embryo, let's say you do IVF and you have your genetically tested normal embryos. Okay, so we've kind of excluded genetic issues. You can kind of say, okay, now we have this uterus. Let's look first. Polyps, fibroids, etc. Those are things that we can fix. Then we can think about, okay, what about timing? Do we think about doing like an endometrial receptivity assay? And then we can also look at things like chronic infections in the uterus, chronic endometritis. But it's really about teasing these things apart rather than one kind of overarching general treatment or tool or something that will kind of help everything. I hope that kind of makes sense.
Yes, that does make sense. Thank you.
Okay.
Thank you for clearing that up.
Mm-hmm.
I've got a couple of more questions before we wrap up. So I have an AMH of 1.5, age 31, triggered on day 6 with first IVF cycle, long protocol. Would you start with low or high stim next round? I don't know if you need more information than that. That's all that's here.
Yeah. So a couple things I will say. So one of the big things about AMH that comes up is that if you Google your AMH, because I'm sure all my patients do, there's two different units for it.
Mm-hmm.
Okay.
Oh, this one says NG per ml.
Oh, okay. See, so there's picomoles per liter, which is probably more common in Canada, and there's nanograms per ml. So NG, ml, or PMOL. And like a 1 nanogram, I think it's like around 7 point something picomoles. So just to be clear, there is a wide difference, but they mean the same thing. And so if you Google and somebody says, oh, my AMH is 2, or it might, just for clarification. The other thing is, so to start on a high dose or to start on a low stim, I think you really have to look at the whole stimulation and kind of what happened. What's the antral follicle count like? What were the hormones going into it? What dose was used? What medications were used? Maybe change up the protocol. Maybe we change up the stimulation, the medications themselves. Now, whether one medication is better than the other, I don't think anybody really has a good answer. But sometimes I just change it up just for the sake of trying something different. Because I'm sure some people respond better to some than others. The other thing is looking, okay, you had the eggs, were they mature? Were they immature? How big were the follicles when they were triggered? How many eggs at retrieval? Did they fertilize? What's going on with sperm? So there's a lot of things. So it's hard for me to kind of give you an opinion or advice, because you really have to take like a global perspective, look at the whole thing to figure out what can be done to kind of maximize your outcome next time around.
Of course.
Yeah.
That makes sense. Thank you for answering that. Why is there an increased risk or occurrence of miscarriage for women with PCOS?
It's a very good question. So the thinking is that it probably has something to do with the hormones. So we know women with PCOS, they tend to have slightly higher levels of male hormones, so androgens. So that's like your testosterone and kind of related hormones. And so there's probably something with that. Now, there are other confounding variables, right? So, we know that women with PCOS, we know that higher weight or obesity will also increase the risk of miscarriage. And we know that women with PCOS there's higher chance of having obesity or having chance. Now there's also medical issues. We know women with PCOS have a higher chance of type 2 diabetes and other kind of metabolic issues. And so it's probably all of these things together that increase that rate a little bit. But really, I mean, the key is, healthy diet, trying to manage a healthy lifestyle as much as possible, trying to attain a healthy weight as much as possible, to really minimize those risks as much as you can. You can't change your biochemistry.
Mm-hmm.
You can't change your testosterone levels, but it's all about focusing on the things that you can control, and to make those little decisions every day.
Great, thank you. Does adenomyosis factor into implantation and pregnancy success?
That's a really good question. And I think the jury's still out, I think, a little bit to some degree, as to what the effect is. And I've definitely heard rumblings that people want to study this, that they want to look at this. I think the problem is that making the diagnosis of adenomyosis is not so clear. Like, there's not really clear guidelines, like what's adenomyosis, what's not, and like what's severe versus what's mild. But it's certainly a very interesting question. And I definitely wonder about that myself. Again, the thing is, even if you have adenomyosis, there's not really much that we can do to fix it or to reverse it. So I think it's just all about focusing on the lining and the uterus and looking at the things that we can control and maximize all of those to maximize our chance of pregnancy.
Great, thank you. This is a good question. How do you advocate for your health with your doctor for more testing when they say no because they can't justify it or it's not going to change your protocol, in your opinion, or the physician's opinion, when testing? Do you think, I'm going to restart that. If it's not going to change your protocol, in your opinion, when testing, do you think it's absolute non-negotiable for certain tests?
I would never say absolutely non-negotiable. I think you really have to, I think it's a discussion with a physician, a discussion with a patient about saying, okay, let's say we do this test. What are we going to do with the results and how is that going to impact things? And I think it's really about an informed discussion and going through the different possibilities of what the test results might be, what we're going to do about that, how we're going to feel about that. And then also looking also at, the cost sometimes too. I mean, some of these tests can be very expensive for the patient. And so I think that also factors into it a little bit too, right? Where if I don't really think it's so helpful and it's going to cost you a lot of money, I'm going to try and not talk you out of it, but definitely going to try and caution you against it because we need to be, because I also want to be responsible too. But I think, there's nothing that's off limits, but I think you just have to be, it's about being able to have that discussion and trying to figure out why you want that test and what the goal is. And I always tell patients, especially with unexplained infertility, many people are often focused on the why. Why am I not getting pregnant? Why is this not working? Because in medicine, I think, or in a lot of the world, we're usually taught, okay, there's a problem. Let's figure out the why. Then we'll know how to fix it. Once we fix it, it'll be fine. Unfortunately, fertility doesn't work that way. With fertility, you have the problem, which is, the not getting pregnant. We probably won't be able to answer the why. And it's very rarely something that's actually like fixable. Mm-hmm. But we can still get you to the pregnancy. We can still get you to the goal. We just kind of take a different route rather than fixing these elements. And I think that's really, it's difficult. It's hard. And I think all of us are naturally like trying to fix problems, right? Because that makes sense. But unfortunately, that's not really the goal in fertility. The goal is the pregnancy. The goal is a healthy pregnancy. Rarely are we going to give you a good answer as to the whys.
Mm-hmm. Yeah. That's a great perspective, and a really good way to sort of think about it, because the end goal is a healthy baby. And so changing the focus can be helpful when we're in these situations. Thank you for answering that. Okay, we have time for one quick question. What is mini IVF?
So I think everybody has a slightly different definition of what it is, and some people call it by slightly different things. But the general idea is that you're doing IVF, but you're doing it with lower doses of stimulation. And again, people will call it different things, with the idea of maximizing egg quality. Usually it's more for, usually we talk about more for women who have low egg numbers or low egg reserves, where we try and try and maximize quality as opposed to quantity. Now, a woman with a good egg reserve, you know, probably not the best way to go, because you can get that good number of eggs. And, you know, in the world of fertility, especially IVF, like, it is a bit of a numbers game, right? Like, you want to get that good number of eggs because, you know, only so many were fertilized, only so many get to blast, and then only so many are going to work. So if we start bigger at the top of the pyramid, we're more likely to get something at the end, right?
That's a good thing to remember, that, you know, after retrieval, or, you know, it's not always the number that's retrieved that makes
10 eggs does not mean 10 embryos.
Exactly. That's good. That's a good reminder.
I'm constantly like this every time I see patients.
Yes, that's a great
and I'm
way
drawing it out. I'm like,
because
that's normal and natural, and that's okay.
That's the thing. It's so normal, and that's the natural process of how this works. So, Dr. Wais, thank you so much for your time today. This was incredibly enlightening for me. And I hope that we've had over 50 people watching this video live.
Wow.
Yeah. So lots of interest. To anybody that's sent your questions, thank you so much for interacting with us. We hope you enjoyed today's session. Please don't forget to follow Dr. Wais on our Instagram at Dr. M. Wais. Also, Dr. Mavis Garcia and Markham Fertility on Instagram. They have incredible information and resources for patients there, and we're thrilled to continue to partner with them. Thank you, everybody, for tuning in.
Thanks so much for having me. I had a lot of fun.
And we will be doing this again, Dr. Wais. I'd love to continue to partner with you in this way.
Yeah, for sure.
This is another episode of Figuring Out Fertility. Thank you so much for joining us. We hope you took away some information today to help you on your fertility journey. Don't forget, Fertility Matters Canada is a registered Canadian charity. And if you have the ability to donate to our charity to help us bring you these information sessions live for free, please donate at fertilitymatters.ca. And I want to take a special moment to thank Bearing Fertility for their continued support of Canadian fertility patients by sponsoring today's session. Thanks, everybody.
Bye.
Bye-bye.